Welcome back everyone. Today we are going to continue our discussion of management of drug sensitive tuberculosis. That is part 2 of our discussion. The outline of today's discussion will be how to monitor and follow up a case of drug sensitive tuberculosis who is under our treatment, what are the causes of clinical non-response, what are paradoxical upgrading reactions, what to do in case of interruption of treatment, what are the various adverse events and management of adverse drug reactions, and what are the various preventive strategies in tuberculosis. So first, coming to monitoring and follow-up. So a follow-up of a case can be of two types. It can be a clinical follow-up and it can be laboratory follow-up. Laboratory follow-up means we have to do various investigations, and that's how. So clinical follow-up. First and most important thing is, first clinical follow-up has to be within 2 weeks of starting therapy. That means when we start antitubercular therapy, first clinical follow-up should be, if no other adverse events happens or no untoward events happens, even if in spite of that, the first regular clinical follow-up should be 2 weeks after starting of therapy, and then every month during the treatment, then after the completion of treatment every 6 monthly for 2 years. Suppose drug sensitive tuberculosis, with the exception of spinal tuberculosis and neurotuberculosis, the treatment is 2 HRJD plus 4 HRE, means total treatment duration is 6 months. That means the first clinical follow-up has to be after 2 weeks, and then for the whole 6-month period, every month during the treatment, the patient has to come to us for clinical follow-up. And after the treatment is completed, that is 6 months are done, then for the next 2 years, patient has to follow up every 6 monthly. That means after the completion of treatment, patient has to follow up at least 4 times. So in clinical follow-up, what are the things that we have to see? We have to see for improvement in clinical symptoms, that is most patients show amelioration of symptoms within 4 weeks of therapy. We have to do a detailed physical examination and look for any signs and symptoms that might suggest deterioration of condition or adverse drug reactions or any worsening of symptoms, worsening of signs. We have to look for side effects of medications that the patient is on, specific side effects, non-specific side effects. We have to treat the comorbid conditions like HIV, severe acute malnutrition, diabetes mellitus, cerebral edema, seizures, pneumothorax, lung collapse, subacute intestinal obstruction. These are the various comorbid conditions that may be present in a case of tuberculosis. And we have to ensure the adherence to therapy, and it should be revisited and ensured in every visit. That means we have to ensure the pill count and we have to enhance the social support. Now coming to the laboratory follow-up. What are the laboratory follow-up parameters? So laboratory follow-up means, first thing is microbiological follow-up. Microbiological investigation, that means we have to do nucleic acid amplification test or smear examination at the end of intensive phase and at the end of continuation phase by the sputum or gastric aspirate or smear and culture. MGIT culture has to be done. MGIT means mycobacterial growth inhibitory tube culture has to be done if no response is seen after 4 weeks, because we learned that most patients show amelioration of symptoms within 4 weeks of therapy. We have to do liver function test. Liver function test has to be done before starting treatment. That means we have to know the baseline liver parameters, and if symptoms and signs of hepatic dysfunction like icterus or itching or decreased appetite or vomiting or pain abdomen, mainly in the right upper quadrant, symptoms like that appear, we have to repeat the liver function test to diagnose a DILI, that is drug induced liver injury. Next, we have to do chest radiograph. Chest radiograph has to be done at the end of therapy. Second is, if clinical non-improvement is seen at the end of 4 weeks, we have to repeat the chest radiograph. And any emerging complications or deterioration, suppose symptoms suggestive of pneumothorax are present, so that is indication of doing chest radiograph itself. And other imaging investigations like non-contrast CT scan of brain or other investigations, CT scan of abdomen, etc., those have to be done at the completion, or if the child shows non-response or deterioration at any stage, at that moment of time, the other imaging parameters have to be done as needed. Next, what can be the causes of clinical non-response? So if a patient who has been diagnosed as tuberculosis, drug sensitive tuberculosis, that means no resistance has been detected in nucleic acid amplification and has been started on HRJD plus HRE treatment. So what can be the causes that in spite of giving the appropriate treatment, the patient is not improving? The first thing can be incorrect diagnosis. Is the case actually a case of childhood tuberculosis? Suppose some other diagnosis is actually present in that case, suppose sarcoidosis or malignancy or something like that, and we are treating him as a case of clinically diagnosed tuberculosis, maybe because we may not have been able to successfully rule out the alternate diagnosis. So incorrect diagnosis is a cause of clinical non-response in spite of appropriate anti-tubercular therapy. Second is lack of adherence to therapy. You have advised, but the patient is not taking due to some issue. The child may be having some side effects, the parents may be worried, the parents are not counseled enough about what is the importance of giving the treatment appropriately and completely. Various reasons of non-adherence may be there, but if in spite of irrespective of the reason, if the child is not sticking to the treatment, that can be a cause of clinical non-response. Next is incorrect drugs or doses. Suppose you have given wrong drugs or at the wrong doses, that means subtherapeutic doses. Obviously the child will not respond as in any other case. And next is inability to retain the drugs. Child is having suppose severe vomiting, and whatever the drug the child is taking, the child is vomiting out, so bioavailability will obviously decrease. So inability to retain the drugs is a common cause of clinical non-response. Next is secondary infection or comorbidity, various comorbidities we discussed just now. And drug resistance. Suppose we have not been able to detect the drug resistance due to some reason. Suppose the Mycobacterium tuberculosis load is very less, or if you have not sent an appropriate sample. Suppose we have sent a sample that has very low yield, like pleural fluid or CSF. Various reasons may be there, but even if we have missed the drug resistance due to some reason and we are giving treatment for drug sensitive tuberculosis, that might be a cause of clinical non-response. And last but not the least, paradoxical upgrading reactions are a cause of clinical non-response. What are that? We'll learn in a bit. So what can be the causes of poor weight gain for a patient on antitubercular therapy? That means patient has tuberculosis, we have given him antitubercular therapy, but in spite of that patient is not gaining weight. What can be the causes? Insufficient intake. In addition to the drugs, the child has to take appropriate calories and protein and all those things. So insufficient intake can be a cause of poor weight gain. Vomiting. Vomiting may be due to the various side effects of medications. The child is taking a lot of drugs. So a lot of drugs can cause a lot of vomiting. So that can be a cause of poor weight gain. Wrong diagnosis, obviously. Comorbid conditions, obviously. Concurrent infections. In addition to tuberculosis, that might be some other infections in the child also, so we have to treat those also, like diarrhea or pneumonia, etc. And poor response to treatment, that is drug resistant tuberculosis. If the child is having drug resistant tuberculosis and we are giving him drug sensitive management for drug sensitive tuberculosis, obviously there will be poor response to treatment, and poor response to treatment means poor weight gain. So now we'll learn what do we do if a patient comes with interruption of our drug treatment. Suppose the patient has been diagnosed as a case of tuberculosis and you have started the patient on antitubercular therapy. After 1 month or 2 months or a certain period of time, the patient comes to you and tells that I had stopped the drug for a brief period of time, for a certain period of time. Now what do I do? So in that scenario, what do we do usually? We see how long has the drug been interrupted. So if the interruption has been for up to 4 weeks, that means less than or equal to 4 weeks, that means we assume that the interruption was very brief, we do nothing, we just resume the therapy. That means we have to give a total 2 HRJD plus 4 HRE, that is 6 months of antitubercular therapy. We subtract the period of interruption and we resume the therapy at that point of time and ensure that the patient gets full 6 months of antitubercular therapy. But suppose the patient has interrupted the drug treatment for more than 4 weeks. Let's think what can be the scenario possible in this case. Suppose the patient actually had drug resistant tuberculosis and you have given the patient drug sensitive tuberculosis management. So will the patient improve? No, the patient will not improve. So the patient will not find any relief from clinical symptoms or signs and anything. So the patient may become non-compliant and may stop the treatment for a long period of time. That is one possibility. Second possibility is this 2 HRJD plus 4 HRE is the complete treatment of tuberculosis. If we treat incompletely, that will lead to killing of the sensitive bacilli and lead to a selective multiplication of the resistant bacilli that remain after the killing of the sensitive bacilli. So that will lead to what? An emergence of resistant organisms, that means an emergence of drug resistant tuberculosis. So if the interruption is for more than 4 weeks, in those scenarios, we investigate the patient for a case of drug resistant tuberculosis. And if rifampicin resistance is detected at that point of time, there is nothing to do. We treat the patient as a case of multi-drug resistant tuberculosis. But suppose if the rifampicin resistance is not detected, then we do what? Then we retreat with HRJD, that is 2-HRJD plus 4-HRE, and test for INH resistance. Rifampicin resistance is not present, that doesn't mean other resistance may not be present. So we have to evaluate for INH resistance, that is isoniazid resistance, and as per the report we treat. If isoniazid resistance comes, we treat as per the regimen of mono or poly INH resistance regimen. So that is the protocol if a patient comes to you with complaint that he had stopped the treatment or interrupted the treatment for a certain period of time. So now coming to an important concept, before that we need to understand this, that active tuberculosis is a state of depressed immunity. That means if active tuberculosis is present in a particular patient, that patient is considered immunocompromised due to TB itself. So when we give anti-tubercular therapy to a patient, what will happen? The immune cells will recover, the immunity status will recover, the patient will go on from a depressed immunity status to an improved immunity status. So focal improvement in immune response will occur after successful anti-tubercular therapy in a case of tuberculosis. So this concept we need to understand what is paradoxical upgrading reaction. So what do we mean by paradoxical upgrading reactions? Paradoxical upgrading reactions manifest in form of enlargement of existing lesions. This is this may also present as in form of unexpected appearance of new lesions. So when does it happen? It happens during apparently adequate anti-tubercular therapy. Why does it happen? Because TB is a condition of depressed immunity. When you give anti-tubercular therapy to a patient of tuberculosis, there occurs improvement in focal immune response. That focal immune response will cause immunological damage to the surrounding structures or the surrounding area. So that immunological damage or immune mediated injury may manifest in form of enlargement of previously existing lesions or unexpected appearance of new lesions. So that is paradoxical upgrading reaction. This paradoxical upgrading reaction is due to improvement in focal immune response. That's why this is not usually associated with systemic symptoms. That means systemic symptoms are usually absent in this case. It usually occurs 3 to 12 weeks after the beginning of therapy. That means the focal immunity improves 3 to 12 weeks after beginning of successful anti-tubercular therapy, and it lasts for 2 months approximately and automatically improves in most of the cases, and it is self-limiting. Without any sequelae, it resolves in most of the cases. Very few cases it may require some active treatment, otherwise it is self-limiting. So what are the various paradoxical upgrading reactions types that may happen? First, it may manifest in form of increase in size of the mediastinal lymph nodes or areas of pulmonary infiltration. That means suppose if a patient had pulmonary tuberculosis and the patient due to some reason is suffering from paradoxical upgrading reactions, it may manifest as increase in size of the mediastinal lymph nodes or increase in areas of pulmonary infiltration than before. It can also manifest in form of appearance of new lung infiltrates. For example, in extrapulmonary tuberculosis, it can also manifest in form of tubercular pleural effusion or increase in size of effusion or appearance of effusion on the contralateral side. Suppose a patient originally had right-sided tubercular pleural effusion, and if the patient will have paradoxical upgrading reaction, he may manifest as new appearance of left-sided pleural effusion. So that is also one of the types of manifestation. Increase in size of lymph node or appearance of new lymph node, as we discussed before, and increase in size or number of lesions like tuberculoma or infections or hydrocephalus, that may also be the manifestation of paradoxical upgrading reactions. So now coming to what are the adverse events and how do we manage those adverse reactions. So in case of minor adverse drug reactions In patients who are able to tolerate the antitubercular therapy, we follow a symptom-based approach with continuation of antitubercular therapy. But if the adverse drug reactions are significant or severe, we prefer hospital-based treatment. In those cases, drug is either withheld or terminated and replaced with a substitute drug, and second-line drugs, adverse drug reactions are mostly dose dependent. So, first we try with reduction of dose. If the reduction of dose doesn't work, we may try with terminating the drug and replacing it with a substitute drug. And most important is psychosocial support, because any patient who is suffering from tuberculosis also obviously will have psychosocial impact. The treatment is long, the complications are various, the side effects are there is an increased risk of side effects just because the patient is taking 6-7 drugs. So obviously the psychosocial support is an important part of managing the adverse drug reactions. So coming to one of the commonest adverse drug reactions, that is QT prolongation. It is mostly seen with 3 drugs, that is bedaquiline, fluoroquinolones and clofazimine. So what are the indications of ECG monitoring before initiation and during the treatment? So if bedaquiline is used in a particular patient, we have to do ECG at the baseline and during treatment. If fluoroquinolone and clofazimine are combined in a treatment, we must do ECG at baseline and during the course of treatment. And what are the cutoff for calling a particular QT interval or corrected QT interval as prolonged? For men it is 450 millisecond, and for females it is more than 470 millisecond. And hypokalemia, hypocalcemia, hypomagnesemia and hepatic and renal dysfunction can aggravate this QT prolongation and precipitate or increase the chances of a patient landing up in Torsades de Pointes. So how do we exactly manage a case of QT prolongation due to antitubercular therapy or having adverse drug reaction due to antitubercular therapy? First we see how much is the corrected QT interval. If the corrected QT interval is more than 500 milliseconds, that means very high, we straight away withhold those drugs which can cause QT prolongation like clofazimine, delamanid, fluoroquinolone and bedaquiline. We correct the electrolytes. Just now we learned hypokalemia, hypocalcemia, all those things can aggravate the QT prolongation. So we correct the electrolyte first and monitor the ECG daily. But if the QTC is not more than 500 millisecond, rather 480 to 500, that means slightly increased, not that much increased, we repeat ECG daily, that is at least twice weekly, and check for the serum electrolytes. If the serum electrolytes are normal and the QTC is 480 to 500 millisecond, that means what? The risk factor is not there and the QTC is like borderline prolonged. So what we can do? We can continue the drugs and repeat the ECG twice weekly and continue to monitor. But on the other hand, suppose if in this case the electrolytes are low, that means there is a high chance of the patient going into further complications just because the risk factors are present. So what do we do in this case? Obviously we withhold the drugs, that is clofazimine, delamanid, bedaquiline and fluoroquinolones, and follow up like that as before. So we have stopped all the drugs that can cause QT prolongation now. We have corrected the electrolytes. We have corrected other risk factors. We are monitoring the ECG daily. Now suppose the ECG has become normal. So how do we proceed from here? So we proceed from here by like we ensure normal electrolytes, ensure normal QT interval as per the gender, and we get 2 consecutive ECGs 24 hours apart and ensure that the QTC in both of them are normal. Then we start the drug that has the least chance of prolonging QTC among the culprit drugs, that is bedaquiline. So first we start bedaquiline and repeat ECG daily. Next, similar stepwise approach. We ensure normal electrolytes, ensure 2 consecutive ECGs 24 hours apart. Then we start the next drug, that is fluoroquinolones, and continue repeating the ECG daily. Next, we proceed in the same step. We ensure normal electrolytes, ensure 2 ECGs 24 hours apart are normal. Then we restart clofazimine. And last but not the least, we restart delamanid at the end and repeat ECG daily for at least 1 week. If we can ensure that, and if we have resumed the drugs or restarted the drugs in this order, and the ECG remains daily, ECG remains normal daily for 1 week, then we can stop the routine ECG monitoring and we can go for an SOS ECG monitoring. Next, coming to the second commonest side effect that can happen due to drugs, that is hepatitis. So a lot of drugs, lot of antitubercular drugs can cause hepatitis, like pyrazinamide, that is obviously the most hepatotoxic. Besides that, isoniazid, rifampicin, ethionamide, para-aminosalicylic acid and bedaquiline, all these drugs can cause hepatitis. So patients are usually, if patients are usually very sick, meningitis or having sputum smear grade 3 plus, then we have to give antitubercular therapy anyway, because the child is very sick due to tuberculosis. So what can you do? We can give streptomycin, fluoroquinolone and cycloserine. Previously in this case, one SLE regimen was followed: streptomycin, levofloxacin and ethambutol. Now it has been changed to streptomycin, fluoroquinolone and cycloserine. But if the child is not seriously ill, we can wait and introduce ATT once the enzymes are near normal. So that means if a particular patient on antitubercular therapy develops hepatitis, whether we continue giving ATT in that child or stop the ATT for some time depends mainly on the clinical status of the patient and overall severity of the illness in that patient. If the child is very sick, having severe manifestations, we have to obviously continue ATT and give an alternate regimen like streptomycin, fluoroquinolone and cycloserine. But if the child is not seriously ill, we should withhold the ATT for some brief period of time, and once the liver enzymes are normal, then we can ensure or then we can resume the drugs. If the enzymes are more than 5 times increased than the upper limit of normal, then we have to stop all the hepatotoxic drugs and continue with at least 3 non-hepatotoxic drugs, that is streptomycin, fluoroquinolone and cycloserine. That means we have to see the enzyme level. If the enzyme levels are higher than more than 5 times the upper limit of normal, then we have to stop all hepatotoxic drugs. We have to eliminate other potential causes of hepatitis like viral hepatitis, alcoholic hepatitis. Obviously those can also happen in a case of tuberculosis. And after the enzyme levels improve, we have to reintroduce one drug at a time. Like we did in case of prolonged QT interval, we have to introduce the least hepatotoxic drug first. Then after a brief period of time, we have to introduce the next least hepatotoxic drug, next least hepatotoxic drug, and in the end we have to introduce the most hepatotoxic drug. And before introducing one drug, we have to ensure that the LFTs are normalizing, and we have to monitor LFT every 3 days when we are doing this, introducing one drug one at a time, one after another. So what is the algorithm? So when we suspect drug induced acute liver injury or drug induced liver injury, that is DILI, so what do we do then? First we see how much is the AST ALT. That means liver enzymes, how much they are enlarged or how much they are increased. If the AST ALT is increased less than 5 times upper limit of normal or more than 5 times the upper limit of normal. So if the AST ALT is increased less than 5 times the upper limit of normal, the bilirubin is normal, the patient is asymptomatic, what do we do? This indicates a slightly less severe scenario. So what do? We have to continue all drugs. Obviously we have to monitor the symptoms, monitor AST ALT bilirubin levels every 2 weekly till they are resolved, and if any time any deterioration happens, we have to switch over to this area. But if no deterioration happens, we have to continue with all the drugs. On the other hand, if the AST/ALT is increased more than 5 times the upper limit of normal, or if AST/ALT is increased more than 3 times of upper limit of normal, with bilirubin also increased more than 2 times upper limit of normal, or if the patient is having symptoms of liver injury, then what do? Then we have to withhold the hepatotoxic drugs, mainly rifampicin and pyrazinamide, because those are the most hepatotoxic. We have to monitor the symptoms, that is monitor the symptoms, monitor AST/ALT, monitor bilirubin levels every week. Here the monitoring was every 2 weekly. Here the monitoring is every week, because this scenario is slightly severe scenario. Then while monitoring, we have to see if the patient is having any improvement or not. If the patient is improving, then we have to restart full doses or withhold drugs gradually, rifampicin followed by pyrazinamide, because most hepatotoxic drugs have to be started in the end, and while in reintroducing one drug after another, we have to monitor AST and ALT level every 3 days after each reintroduction to ensure no deterioration before the reintroducing the next drug. But suppose if the patient doesn't show any signs of improvement or patient deteriorates, then what do? We have to think about replacement drugs, like we told, streptomycin, cycloserine, and fluoroquinolones. So another common side effect is hearing loss, mainly seen due to amikacin, and it can also be seen in if the ear has wax or medullary infection. So those causes obviously have to be ruled out first before attributing it to amikacin. We have to compare with a baseline audiogram if available. So that's why it is an important step to get a baseline audiogram also. We have to change the dose of the injectable drug to twice to thrice per week rather than daily, and we have to discontinue injectable drug if the hearing loss worsens despite the dose adjustment, and we have to add the additional drugs to reinforce the regimen. So how do? First, a case comes with hearing loss, suspected hearing loss. We have to obviously rule out wax and medullary infection. We have to do an otoscopy to rule that out. If those have been ruled out, we have to do an audiometry. So if the hearing threshold is less than 40 decibel at all frequency, or the threshold is more than 40 decibel at 8000 Hz, we have to discuss the implications with patients and decide accordingly. But if the hearing threshold is more than 40 decibel at 4000 to 8000, more than 40 decibel at 2000 to 4000, or more than 40 decibel at 1000 to 8000, in all these three scenarios, we have to stop any aminoglycosides that are given and think about the scenario, and like we discussed before. So these are the various side effects and various drugs that can be attributed to those side effects as we discussed. So you can pause and go through all this. Now coming to one of the most important things, that is how to prevent tuberculosis, because obviously prevention is always better than cure. The drugs are a lot, the side effects are a lot has to be discussed, lots of complications can be seen, the diagnosis is difficult, lots of high-end investigations have to be undertaken. So obviously our first goal should be to prevent tuberculosis. So what is its significance? India has the highest burden of TB globally. Among all the cases of tuberculosis arising every year all over the world, India contributes the highest. So India has the highest burden, and 5 to 10% of those infected will develop TB disease over the course of their lives. That means if 100 cases or 100 persons get exposed to tubercular bacilli and get infected, 5 to 10% of those develop a tubercular infection in their lives. So that is a lot, and 71% of household contacts of pulmonary tuberculosis patients have a baseline tubercular infection. Children are more susceptible to TB infection because we have discussed all that in our first lecture, and they are more likely to develop active TB disease and more likely to develop severe forms of tuberculosis also. And the risk of tubercular infection increases 16 to 21 times in case of HIV co-infection, and tuberculosis preventive treatment has to be given after ruling out active tubercular disease. So what are the strategies to prevent tuberculosis? Early detection and treatment of infectious cases has to be done. Airborne infection control practices has to be undertaken. We have to undertake contact screening and provide tuberculosis preventive therapy. We'll learn that in a bit. And we have to provide appropriate BCG vaccination coverage to prevent tuberculosis or to prevent childhood. So now we are going to learn about what is tubercular preventive therapy. Tubercular preventive therapy has to be always given after ruling out active tubercular disease, because it is essentially a monotherapy. So if you give tubercular preventive therapy without ruling out active TB, what you are doing, you are giving monotherapy to a patient who is suffering from tuberculosis. So you are essentially giving rise to a case of drug resistant tuberculosis. So that should be avoided. So always rule out active TB first before giving TPT, and it has to be given irrespective of BCG vaccination or nutritional status. So what is tubercular preventive therapy? Mainly three groups of people are eligible for tubercular preventive therapy. Let's come to the first group. First group is people living with HIV, especially two populations. One is adults and children more than 12 months. Second is infants less than 12 months with HIV in contact with active TB patients. That means all infants are not eligible for TPT. Infants with HIV who are in contact with active TB, those are eligible for TPT, and every other child more than 12 months, that means elder than infants, are eligible for TPT among the HIV positive population. Second is household contacts of pulmonary TB cases less than 5 years of age. Suppose you have diagnosed a pulmonary TB case, and in his household or in her household there is another person who is less than 5 years of age, that person is eligible for tubercular preventive therapy. So what do we do in this case? We have to give TPT to all after ruling out active TB. So we have to rule out active TB in these patients and then give tubercular preventive therapy. This is the first population. What is the second population? Second population is household contacts of pulmonary TB more than 5 years of age. Less than 5 years of age, you just rule out active TB and give TPT. But household contacts of pulmonary TB, if it is more than 5 years of age, what do we do? And the third population, that is other risk group of individuals. That means other individuals who are at increased risk of developing tuberculosis. That means immunosuppressive therapy receiving patients, anti-TNF therapy receiving patients, patients on dialysis, patients preparing for transplant and having silicosis. All these patients, what do? We rule out active TB and look for tubercular infection. If tubercular infection is positive, we give tubercular preventive therapy. So in the first group and in the second group, in the first group you rule out active TB and tubercular preventive therapy is given. In the second group you rule out active tuberculosis, and among the TBI positive patients you give tubercular preventive therapy. So we have basically two options available. First option is 6 months daily INH, that is called 6H, and second is 3-month weekly INH and rifampicin for more than 2 years, that is called 3HP. So what are those therapies? First, coming to 6-month INH therapy. For more than 10 years, the weight range is 5 milligram per kg per day. For less than 10 years, the weight is 10 milligram per kg per day. And in the 3HP, that is 3-month weekly isoniazid and rifampicin therapy, for mainly meant for children more than 2 years. The dose for more than 14 years is INH more than INH and rifampicin 300 plus 300, and the dose for 2 to 4 years is INH 100 plus rifampicin 150 milligram. So what are the general measures to prevent spread of infections? Adequate ventilation into and out of patient's room. Any patient that you keep in a particular room, patient suffering from tuberculosis, adequate ventilation should be present. Spatial separation of at least 3 feet between the beds should be present. Patient should have a face mask or cover for his mouth. Patient should practice healthy or appropriate cough etiquette. Patient should practice appropriate hand hygiene, and proper cleaning of clothes and disposal of waste of the patient must be there. So what is contact screening? All the close contacts, especially household contacts, must be screened, and reverse tracing to search for active TB cases must be done. Reverse tracing means which persons the current patient had contact with, and particular attention to be given to contacts with highest susceptibility of tuberculosis, like we learned just now, immunosuppressive therapy receiving patients or immunocompromised patients and patients with silicosis, all those things. So how do we manage household contacts of pulmonary TB? We just learned that household contacts of pulmonary TB less than 5 years means we have to rule out active TB and give TPT. More than 5 years means we have to rule out active TB and give TPT to all those with TBI. So all household contacts should be given TPT after ruling out active TB regardless of age. Children less than 5 years, TPT is to be given after ruling out active TB without TBI testing, and children more than 5 years, we have to do chest X-ray and TBI testing and then decide on the tubercular preventive therapy. And it should not be deferred if testing is not available. Suppose chest X-ray and tubercular infection testing is not available, it should not be deferred. TPT should be given. So what are the various treatment outcomes of TB patients that you have treated? First, coming to what is meant by cured and treatment completed. Suppose a patient has been diagnosed as microbiologically or clinically diagnosed tuberculosis at the beginning, and if you give complete treatment, 2 HRJD plus 4 HRE or 2 HRJD plus 10 HRE depending on the type of tuberculosis, and at the end of the therapy, at the end of the complete therapy, patient has been documented to be smear or culture negative. You do a smear or you do a culture and that comes negative at the end of therapy, it is called cured. But suppose at the end of therapy you have no records or you have not done the smear or NAT or whatever, and you have no records to show whether the child had responded microbiologically or not. So in that case, it is called treatment completed, given that the patient has not failed or deteriorated. That means there is clinical improvement, there is no microbiological or clinical deterioration also, but there is no concrete proof that the patient has responded in form of a negative smear or culture. That is called treatment completed. And both these cured and treatment completed are included under one group, that is called treatment success. So now what is treatment failure and failure to respond? So one important concept to know, that just we learned that most of the tubercular infection patients start to show improvement or clinical or microbiological response around the 4th week mark. So that is important to know. So who is a treatment failure to respond? Failure to respond means even after 4 weeks of compliant intensive phase, if the patient doesn't show any microbiological conversion or clinical response. Suppose a TB patient had come to you with prolonged fever or prolonged cough, given diagnosed to be a case of drug sensitive pulmonary tuberculosis. You give him 2 HRJD plus 4 HRE. So after 1 month, the child suppose doesn't have still has fever or still has cough. So that means the patient has failed to respond clinically, because the clinical response should have appeared at around 4 weeks of time. So that is called failure to respond. What is failure? At the complete end of treatment, if the child is still smear positive or culture positive. That means at the end of 4 weeks, if the child has failed or not shown any improvement, it is called failure to respond. At the end of complete treatment, that is 2 plus 4, that is 6 months, if the child is still positive, he is called treatment failure. Who is lost to follow-up? It is self-explanatory. If no treatment was interrupted for more than equal to 2 consecutive months, that means any child who has taken antitubercular therapy for more than equal to 2 consecutive months and now has been lost to follow-up, then it is called lost to follow-up. Non-evaluated means no treatment outcome has been assigned and not has been evaluated. Treatment regimen changed. It is self-explanatory. The first line regimen has been changed to drug-resistant tuberculosis. Suppose a patient was drug sensitive tuberculosis at the beginning, but due to something in between the treatment, the patient has been now diagnosed to be a case of drug resistant tuberculosis, so the regimen has to be changed. That is called treatment regimen changed. And of course, if the patient dies, we have to document it as died. So what are the clinical learning points we learned today? Both clinical and laboratory follow-up of all the patients undergoing treatment as per the protocol has to be taken. Concurrent infection and comorbidities are the common cause of clinical non-response. We learned what are the paradoxical upgrading reactions, how it manifests and what is its mechanism, what are the major and minor adverse drug reactions and how they should be managed appropriately. And as always, prevention is better than cure. If you like this video, press like, share with your friends and subscribe. Thank you.